Good morning. My name is Lorenzo Tinti, and I work as a clinical neurophysiologist in Pavia, Italy. Today, I'm going to talk about our paper titled Research Considerations for Prospective Studies of Patients with Coma and Disorders of Consciousness by the members of the Prospective Studies Working Group within the Curing Coma Campaign. I want to thank them and all the collaborating members of the Curing Coma Campaign. So we have developed a narrative review of studies on coma and disorders of consciousness, also known as DOC, to identify common limitations and pitfalls in study design that could have limited research progresses so far. Secondly, we have provided practical suggestions to overcome this limitation in future research. Our first consideration was that coma is the consequence of many diverse brain injuries, like trauma, cardiac arrest, or strokes. And while we have some good knowledge about how to manage these underlying conditions, we still strive to properly define, manage, and follow up the associated disorders of consciousness, including coma. This is a problem because without adequate definitions, it can be very hard to gather informative data and therefore to plan clinical trials to test treatments. The most common issues with existing studies are inclusion criteria, follow-up timings, definitions of important outcomes and confounding factors, and study designs. All of these vary widely among studies, so it turns out difficult to combine them into meaningful knowledge. Part of this heterogeneity may come from different research priorities among the many healthcare professionals that manage DOC patients, both at the acute and at the chronic stage. These different professionals may prioritize different features of the clinical presentation of these patients and use somewhat different definitions for DOC. This has also been highlighted in the Come Together survey by the members of the CCC. To tackle this issue, we highlight that recruitment should probably be based not just on the separate settings of care, either intensive care units, emergency departments, stroke units, rehabilitation wards, or long-term facilities, but rather be based on common DOC phenotypes, or better, on the so-called endotypes, which define patients according to clinical behavior as well as physiological and biological data. This has been described in a previous Curing Coma Campaign paper introducing the access approach and framework. This will also allow to identify patients early on during the continuum of care and keep track of them along the subsequent stages. We stress the importance of evaluating for clinical confounders, for example, metabolic derangements and focal neurological deficits, which could mask the presence of residual consciousness. We also discuss how to select useful outcomes and comprehensive scales for following up patients and define their progression, both in the ICU and the long-term facilities. Finally, we discussed the choice of clinical variables to account for in clinical studies and statistical tools to analyze this data meaningfully. Altogether, we call for a multidisciplinary evaluation of coma and DOC patients from the acute to the chronic stage, and recommend using homogeneous tools all along, including common data elements for disorders of consciousness. So thank you again for watching, and feel free to share this World Coma Day contents with your collaborators and help us carry on research on these patients.